welcome to our 96 Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Iheno Tadala, a general physician and first aid trainer from Blue Health Ethiopia. So our today's webinar topic will be on second part series from the previous one, which is the nutrition care for cancer treatment and recovery. So our speakers are Stephanie Maxson. She earned her master's degree in clinical nutrition from Bastyr University in Seattle, Washington, and is a registered dietitian in the United States. She has worked with cancer patients of all ages at several hospitals, including MD Anderson Cancer Center in Houston, Texas. So the second speaker is Dr. Maxson Makonnen. Dr. Maxson earned her Doctor of Medicine degree from St. Paul Hospital Millennium Medical College and had a double master's degree in public health and health science. Stephanie, the stage is all yours. You can begin.
Thank you so much. Thank you for the invitation, and thank you everyone for attending today. Hopefully some of you were here for part one a couple of weeks ago. We're going to continue with more information about nutrition care for cancer treatment and recovery. Oops, let's see. Okay, we'll get the bugs out of the way first. Okay. So our learning objectives for tonight are to look at nutrition screening of cancer patients, also conducting nutrition assessment, determining nutrition goals and plan, and then at the end we'll address a few of those frequently asked questions, in particular questions that cancer patients ask us about nutrition and cancer. And I want to start off by saying that as I was preparing this presentation, it became apparent to me how ambitious the amount of material is that I'm going to cover tonight. It's a lot of material for one seminar, but my hope really is that everyone will find some new information to take back to your practice. For dietitians, maybe some new insights into the nutrition care process, especially as it relates to cancer patients. And for doctors and nurses, an improved understanding of what the dietitian brings to cancer patient care, which may lead to enhanced collaboration and ultimately improved patient outcomes is what we're looking for. So with that, I'm going to dive right in and give you just a little bit of background. So malnutrition is an imbalance between the nutrients in your body, an imbalance between the nutrients your body needs to function and the nutrients you consume. And malnutrition can be both undernutrition, which is weight loss, or overnutrition, which is typically weight gain. But when discussing cancer patients, we're most often concerned about undernutrition or weight loss. 40 to 80% of cancer patients develop malnutrition during their illness. And we know that malnutrition is associated with increased morbidity and mortality. They tend to have more side effects from treatment, delayed wound healing, decreased quality of life. It may delay their treatment, which could, again, reduce their risk of cure. And sometimes they have longer hospital stays or higher readmission rates. So considering the nutrition risk and consequences associated with the cancer and cancer treatment, proactive identification and treatment of patients at nutritional risk is essential to support survival, recovery, and quality of life. Early nutrition therapy has been shown to prevent, treat, and limit the consequences of cancer-related malnutrition. Therefore, it's recommended to take a proactive approach to nutrition care of cancer patients. This proactive approach includes 3 steps. First is nutrition screening, second, nutrition assessment, and then preparing a nutrition goals and a plan. And the goals and plan are technically they're part of the assessment, but it's really a different process. So I'm going to address them separately. And because this is such an ambitious approach today, and you may have a lot of questions, or you may need more resources at your hospital or clinic, I want to recommend these couple of resources. They're both from the American Dietetic Association, and they're both available in hard copy, but also through the internet, so you can pay and have immediate access to online book. So I think it's a good idea to have a good resource on hand at your hospital or clinic, even if it's just one resource that everybody can share and look up more information to help guide you. Okay, so we're going to start by talking about nutrition screening. Nutrition screening is the first step in proactive nutrition care for cancer patients. The purpose of nutrition screening is early identification of malnutrition risk, followed by referral to a dietitian for improved patient outcomes. And the first screening of cancer patients should be done at diagnosis. This provides a baseline for future screenings and assessments and ensures that early malnutrition risk is not overlooked. There are many different nutrition screening tools available, and there's no one agreed upon golden standard. So it's most important, these things are most important to keep in mind. You want to use a tool that is validated, preferably something that's quick and easy to use. It should be conducted by well-trained staff, preferably a nurse, doctor, or dietitian. And I do recommend, I'm going to go through my preferred screening tool with you tonight, but it's going to be, again, a pretty quick review. So I recommend that you, if you're going to start implementing this, you want to organize a training session at your hospital to get everybody who's going to use it up to speed. That increases the quality of the information you get from the screening, and also ensures that everybody's using the screening the same way so that it's consistent. And then finally, when patients are screened to be at malnutrition risk, that they're referred to a dietitian for further assessment. Okay, and there are 4 features of a nutrition screen. They should include a collection of the current nutrition status, looking at weight, and also a physical exam. The stability of their current condition. Have they lost weight or gained weight involuntarily? Do they have a potential, is there a potential that their condition will worsen? For instance, they're eating less, they're unable to eat well because of those nutrition-related side effects we talked about a couple weeks ago. Maybe they have nausea, taste changes. And is there a negative influence of cancer on the nutrition status? Again, those side effects, which might include changes in metabolism. So this screening tool is called the I always forget the second one, patient-generated subjective global assessment. And I've given here and also a few other places a link to the website. And this website you can download for free the screening tool. It's a 2-sided form. They also have like a web-friendly version, so patients and clinicians can complete it on an iPad or a computer. And there's a lot more detailed information on their website about how this tool was created, how it was validated, and instructions for using it. There's a lot more information there. So if it's something you're interested in, I strongly recommend you look at their website. But we're going to go through it a little bit. And the main reason I recommend this one is because it's been validated in cancer patients, and it's the most accepted and widely used screening tool for the cancer population. And I should say adults only, this does not include children. Pardon me. The screening tool is more thorough than other screening tools that you'll find. Sometimes it's referred to as a mini assessment, and you'll notice that the name of the screening tool is assessment, but it's used as a screening tool. So the name's a little bit confusing, but it's a screen. The first page is designed to be completed by the patient, but consider whether the patient might need some assistance in order to ensure that the information that you're collecting is reliable. And then the second page is to be completed by a trained clinician, and ideally someone who has prior experience with that patient, unless you're assessing a new patient for the first time. All right, so this is the first page of the screening tool. And again, this is the page that is designed to be completed by the patient if you assess that they're able to do so. And I'm just going to talk through these boxes pretty quickly. But again, you can spend a lot of time reviewing more information on the website, and I encourage you to do so. So the first box is looking at their weight, what's their current weight and height, and how much weight have they either lost or gained. The second box is looking at their food intake. Are they eating normally or more or less than usual? And has their diet changed? Maybe they're not able to eat solid foods anymore. They're only eating liquids. The third box is looking at all those nutrition-related side effects of cancer that we talked about 2 weeks ago. So now you're well versed in how to recognize those and that those are important for nutrition and malnutrition during cancer treatment. So we want to find out which of those they're experiencing. And then the fourth box is looking at their activity. Are they able to perform normal activities, or are they less active, have less energy than usual? And then you'll score these according to the numbers that are given in parentheses at the end of each line. Okay, and then this page is, going to make sure I'm on the right page, yes. So this is the first half, actually, of the practitioner completed form. And the first box to the top left is how you're going to score their weight loss. And probably you don't need any instruction in this, so we're not going to spend time on it, but basically what percentage of their weight have they lost in the last month or 6 months, and then it assigns a score based on that number. The box at the top right is looking at their diagnosis, and so probably all of these patients are going to have a check in the box next to cancer. They may also have another diagnosis that's relevant. And you'll notice one box actually is for patients 65 and older, so age can also be a risk factor. And then the box across the bottom is looking at metabolic demand, and that's really just assessing fever and corticosteroid use, medical use, of course. And again, I'm not going to go through the details. You can read this on your own and understand how to assess and assign the scores. And then they give you a box for each of these larger boxes. They give you a little box to put the score. Okay, and then the last part at the top is looking at the physical exam. This is assessing whether the patient's had any muscle loss or significant fat loss, which would indicate malnutrition or malnutrition risk. And this nutrition-focused physical exam is actually also part of the nutrition assessment process, and I'm going to talk about it in more detail when we get to nutrition assessment. So we will be coming back to this. The information I give you in just a little bit on the physical exam, you can apply also to this screening tool. And then the last part here tells you how to assign the scores. So if their total scores for the entire form are basically less than 4, they may just need a little bit of education, which might be provided by a dietitian or even a nurse. But if they get a score of 4 or higher, you're going to be referring them to a dietitian for a nutrition assessment. And that's where we're going to go deeper into that question. Let's see, and I just want to make sure I'm not forgetting something. Yeah. So I I also want to include this other screening tool. It's the malnutrition screening tool. It's also validated. It's much, much shorter. There's only 2 questions. Has the patient lost any weight, and are they eating normally? So it's much less specific. And for cancer patients, when you consider that, especially for some types of cancer, they may be in treatment for a long period of time, and knowing the nutrition-related side effects of many cancer medications, I do recommend the more thorough tool. But if you're working in a hospital and you have a lot of dietitian support on your staff, the shorter tool might be appropriate. It's valid for screening patients at the time of hospital admission. And if you have a strong dietitian support on your staff, this may be enough. So this is the much shorter screen that I can recommend. And again, there's a link here where you can find more information about the screening tool, but it's very, very short. So the screening protocol basically begins screening early, ideally at diagnosis. The advantage of screening at diagnosis is it provides a patient baseline to which future screenings and assessments can be compared. And then screen regularly. And that frequency can depend on the type of cancer and the type of treatment the person's receiving. For cancers with a higher rate of malnutrition, those patients should be screened more often. Whereas patients who have a type of cancer with low rate of malnutrition, maybe you can screen them less often. Oftentimes this is something a hospital or a hospital system makes these determinations as a group so that everyone's doing it consistently. And then the results of that screening should determine whether future action is needed and what type of action. And this triage list is just taken from that screening tool that we just went through. I just enlarged it so it's easier to read. But 4 points and over is considered a referral to the dietitian for further assessment. They also list for 9 points and higher, they might need something even more aggressive. So maybe the dietitian and the doctor meet up in a short period of time to really discuss some more aggressive nutrition care. Okay, so that takes us to nutrition assessment. You've done the screening. This patient's been referred to the dietitian for assessment. What happens next? Nutrition assessment is the second step in proactive nutrition care. And the purpose of the assessment is to collect and interpret data needed to identify nutrition-related problems and their causes. The goal is to identify patients who need support in order to avoid malnutrition or to reverse malnutrition, to maintain or restore nutrition status, to recommend medical nutrition therapy, and to monitor intervention efficacy. And ideally, the nutrition assessment is conducted by the clinical dietitian. If you don't have a dietitian on staff, that's something else to consider, whether you're able to hire one or whether this task can be assigned to someone else who's adequately trained to carry it out. The nutrition assessment should include data collection, and that's pretty significant, so we'll go through that. There's also a clinical assessment of the patient's nutrition status, setting nutrition goals, and creating a nutrition plan. There's 5 types of data that will be collected. There's medical and social history, nutrition and food history, anthropometrics, medical and biochemical data, and that nutrition-focused physical exam. I recommend you create an intake form, which includes sections for all the data you're going to collect. Kind of a pro tip, in my opinion, is to collect as much data as you can from the medical record before speaking with the patient. This will save time in the patient consultation. It also increases the patient's confidence in you as a clinician, and it will help you to know where to focus your questions when you do speak with the patient. So regarding the data around medical and social history, of course, you want to know what their cancer diagnosis is and their cancer treatment plan, if that's been decided. previous diagnoses and surgeries, especially those that affect their nutrition and nutrition care. Any nutrition-related side effects they've already reported. And some relevant social information. In particular, do they have family at home or do they live alone? It's possible they're going to need help buying groceries and preparing foods while they're sick. So what kind of support do they have? Also asking about their work and their education might give you some information about their knowledge about food and nutrition. And their socioeconomic status might help you to understand how well are they able to afford some of the foods that they might need in the process. Around their nutrition and food history, it's important to ask about food allergies, their preferred diet, their knowledge and beliefs about food and nutrition. Do they take nutrition supplements? What's their physical activity? Do they have a regular routine? And then I always collect a 24-hour diet recall from patients. For a patient who reports that they're still able to eat well and hasn't lost any weight, I ask them about sort of a typical day. A typical 24-hour day in their eating. For a patient who reports that they really have been unable to eat normally, they've eaten very little recently, I ask them what they've eaten in the last 24 or 48 hours to get an idea of what they're really able to do. Anthropometrics, that's all of those physical measurements when you measure their weight and height. And you want to really keep a weight history going. It becomes especially important for a patient who maybe was overweight to begin with. They can be losing weight and still be overweight. And so that weight loss might not be noticed if you haven't been measuring it along the way. And then you can use that information to calculate body mass index and ideal body weight. For children under 18 years, you want to track their height and weight and body mass index on growth charts. And for children under 36 months, you want to track their head circumference on growth charts. And if you work with children and you're not familiar with growth charts, I highly recommend that you get educated on those and start incorporating them into your practice. For the medical and biochemical data, you want to collect all the nutrition-related lab values, in particular, electrolytes, blood sugar, protein status. If there's been any imaging of their digestive system, it's not available for all patients, but it could be important. The results of those images could be important if they're having trouble digesting or if they've been constipated. That might be important. And then as for dietitians in particular, the longer you work with these cancer patients, you'll know right away when you read the medication list which side effects they're going to be likely to have. Are they going to be experiencing nausea or taste changes just by looking at which medications they're getting? It's also important to see if the doctor's already prescribed any kind of side effect management like appetite stimulants or anti-nausea medicine. If they haven't and the patient's nauseous, it might be something that you would recommend. Okay, and then so we've gone through 4 of the pieces of data to collect. The last one is this nutrition-focused physical exam. Because many cancer patients are at risk of malnutrition at some point in their treatment, this exam is very important for this patient population. I recommend that you don't wait until the patient is losing weight to perform this exam. Ideally, you complete this physical exam before significant weight loss has occurred so that you have a baseline for comparing. Again, a baseline is important for comparing future exams. And as I mentioned earlier, this is also part of the that recommended nutrition screening tool. This nutrition-focused physical exam, it's a long name, is specifically designed for adults. There is one that's designed for children. And I'll tell you at the top here also, I've provided to the seminar organizers this handout in the form of this table, and also I'll show you here, it's a 2-page table, and there are 2 pages on the physiology, so you know which muscles and bones your you're doing your physical exam around in order to make these determinations. So this 4-page handout I've provided to the seminar organizers to share with you to incorporate in your practice. Let's see. Okay. However, clinicians should receive more thorough training. What I'm going to share with you tonight is not what I would consider a thorough training on this physical exam process. It's just an introduction into what it is and why it's important. I personally attended a training. It was 2 or 3 hours, and it included practicing the exam. People in the class practiced it on each other so that we felt comfortable when it came time to performing the exam on patients. Again, it ensures that everyone's doing it the same way. There's some consistency, especially if there's going to be more than one clinician performing the exam on each patient, over time. You want there to be consistency from one to the next. So I'm just going to review the highlights briefly now. And like I said, you've got the information as a handout you can review, and I've included in that handout also 2 references. So if you do want to implement this at your hospital, you're not currently doing it, there are some really strong references you can purchase to use to train yourselves and train each other in doing it appropriately. All right, it was a long introduction for what is quite a involved nutrition-focused physical exam. But I'm going to summarize it here. It really is 2 parts. You're looking at subcutaneous fat loss in just a few areas, and then also muscle loss in a larger number of areas. So for the fat loss, you're looking at the orbital region, which is under the eyes, and people who have lost fat there, their eyes tend to look sunken or have dark circles. You're going to look at underneath the tricep and bicep. You're really pinching this skin underneath the arm to assess how much fat is in that between the folds of skin when you pinch. And this, I should say, this exam becomes more important the more times you do it. You start to notice more of a change, and that's what's really important. Is there a change from baseline as time goes through a person's treatment? There's the thoracic and lumbar area. You're looking at how obvious the ribs are and the iliac crest, how prominent those are. And then for muscle loss, you're looking at the temple region next to the eyes. Is there a depression there? The clavicle up at the neckline. In women who are well nourished, this clavicle can still be visible, but in men who are well nourished, it's typically not visible. But again, as they lose muscle, that clavicle becomes more obvious. So how prominent is that? The acromion is next to the shoulder here. So in muscles that are well developed, they should have a rounded shoulder. With muscle loss, it's going to be more flat or square, and the bone will become prominent. The scapula is on the back. You're going to be looking again for prominent bones in the scapula and spine. With the hand, you ask the patient to hold the fingertip and thumb together, and you're looking at this pad of muscle here. It should be rounded in a well-nourished person, and it will become flat or even depressed in someone who is malnourished. The patellar region around the kneecap, how prominent is the kneecap? Looking at the quadriceps, is there a depression there, or is it well-rounded? And then the calf muscle. A well-developed calf muscle should be quite rounded, but if it's thin and depleted, that could indicate malnutrition. So again, a very quick overview, but I want to say something else about it, and I can move to another slide to give you something to look at. But speaking to the dietitians in particular, dietitians were not typically used to doing physical exams. I know for me it felt strange at first. So a couple of tips. First, ask the patient's permission before you start touching them. Explain the exam will take 1 to 2 minutes, and that the purpose is to support their health and quality of life through treatment. And like all clinical skills, your skills for this physical exam will develop with experience. So practice it with all your patients so that you can better be able to distinguish between mild, moderate, and severe malnutrition. Practice brings that experience, brings that clinical judgment. Okay, so you'll receive all these in the handout so you can give it more thought. Okay, so now that you've collected all this data, that was a lot of time spent on data collection, but that's an important piece. Now that you've collected all this data about your patient, the dietitian is going to apply their professional training and knowledge, their critical thinking skills, and their clinical judgment to evaluate all the data, make a clinical assessment, and to develop appropriate goals and recommendations. And also, you're going to learn from each experience to enhance that clinical judgment. And I say that as an encouragement to new dietitians and also dietitians who maybe been practicing for a while but are new to cancer care. When I first started with cancer patients, the first year felt like a pretty steep climb that I had to do just in learning and growing my clinical judgment. But it comes with experience. You just keep working at it. Okay. So the clinical assessment includes 3 things. You're going to include your estimated calorie and protein needs. And this goes back to what we talked about 2 weeks ago. We spent a bit of time on how you calculate those estimated calorie and protein needs for children and adults. So use that information to calculate that. You're also going to recommend a diet, and especially if a person is not tolerating a regular diet. Maybe they need pureed foods because they have pain in their throat, a low fiber diet if they're having a lot of diarrhea, a low carb or low sugar diet if they're having high blood sugars from prednisone therapy. That's a determination that you can include here. And then lastly, you'll have an assessment statement documenting the patient's nutrition status and the evidence which leads you to that conclusion. Sometimes it's called a nutrition diagnosis, but I found that doctors don't always appreciate that. It can be confused with the medical diagnosis, so assessment statement also works. And here are just some examples. I won't read through all of them with you, and I will say that there are many, many, many possibilities. This is truly just a few examples. So don't be limited by what you read here. But I want to say you should prioritize the nutrition problems according to which problems are most significant to the patient's survival and quality of life. You're not limited to just one, but you don't need an exhaustive list. You really want to prioritize their most significant problems. And then, let's see. Yeah, avoiding and correcting malnutrition are typically top concerns in cancer patients. So, so I've also written these in a way as an example to give you an example of how to write it. So you show the evidence for your assessment. So inadequate intake due to chemotherapy-induced nausea as evidenced by their 4-kilo weight loss in 2 weeks. Severe malnutrition due to increased metabolism with pancreatic cancer, as evidenced by significant muscle loss on physical exam. You're demonstrating which data you've collected that is evidence for your conclusions of what the concerns are. There's one example here the last one is an example for a child, inadequate calorie and protein intake due to poor oral diet tolerance, as evidenced by patient falling off their growth curve for height. So that would be a concern that they're falling behind in their growth and development. All right. So we're moving ahead to the nutrition goal and plan. Like I said, this is part of the assessment process, but it's really, it has some unique considerations. Once the nutrition assessment is complete, the dietitian can choose appropriate nutrition goal and develop recommendations to support the patient in reaching their goal. Some common nutrition goals during and after cancer treatment include weight maintenance, weight gain, improve oral diet intake, maintain or achieve adequate nutrition status, prevent or reverse malnutrition, maximize quality of life. That last one applies to everyone, but I would say I use it most in patients who may be incurable, for example. So they're if they're considered, the prognosis is considered poor, then you really want to look at how you can support them nutritionally with optimizing their quality of life at the end. One example for children, again, promoting age-appropriate growth and development is always top. It's always number one for kids. And when writing a goal statement, it should be written in a SMART goal form. It should be specific, measurable, achievable, realistic, and timely. And here again is quite a long list. Again, it's not an exhaustive list. There are many, many other options, many other possibilities. But let's see, for example, increase calorie and protein intake. You want to say exactly how many calories per day and how much protein per day, supporting weight gain to reverse malnutrition. Reduce consumption of high fiber foods to mitigate chemotherapy-induced diarrhea. Follow a low carbohydrate diet to maintain fasting blood glucose below 100 milligrams per deciliter. These are just examples. There's many possibilities. And then the last step will be to develop their nutrition plan. And this commonly includes education that you provided in the consultation. It could be education items that you want to make sure that you do on a follow-up visit. Maybe the patient has expressed interest in eating for cancer prevention, but it's not the appropriate time to educate them on that topic, so you want to keep track of that. You put that in their follow-up. This is something to do once they're finished with their treatment. It could be a monitoring plan or recommendations to the medical team. And again, I'm offering you some examples here, but not an exhaustive list. So you may have educated the patient on increasing protein-rich foods to meet their daily protein needs of X grams per day. Or the patient to drink X cans of Ensure by mouth daily. The next two are recommendations for the medical team. Consider antiemetics to improve oral diet tolerance, or consider appetite stimulant to increase oral diet intake. The last one, if you have the opportunity to provide enteral nutrition support, you could recommend initiating nutrition support until the patient is tolerating an oral diet. That's important if the patient is, they're not going to be able to eat for quite a long time. Maybe they're getting radiation therapy to the throat. They've already lost quite a bit of weight, or they're at risk. And then you want to say exactly, you want to figure out exactly how much Ensure they need and what that's going to provide. Okay, so this has been, like I said, a really broad overview, quick overview of the nutrition assessment process, which I hope will enhance in some way your practice as a dietitian, conducting nutrition assessment, and also improve the medical team's communication about nutrition in order to improve patient outcomes. And here just is a very, very brief example of how your note could be structured. I often separate the data between subjective, which is patient-reported, and objective data, which comes from the medical record or the medical team. And then you've got your assessment, goal, and plan. Okay, how are we doing for time? Oh, not too bad. I did think it was going to take longer than that. Okay, well, we've got some time to address these questions then. And this was definitely on my list too, but when I asked you all last week which nutrition-related cancer questions were interesting to you, a lot of people said they wanted to know about does sugar feed cancer? I get this question from many patients and also providers. I kind of wish I had €1 for every time someone asked me this question. But truly, there is no evidence of a direct link between sugar consumption and cancer risk. However, I do think it's super important. It's important for us to know and also for patients to know that high intake of sugar contributes to obesity, which is known to increase risk of cancer, many types of cancer. Also, a high sugar consumption contributes to higher blood insulin, higher blood sugar, also inflammation markers, which have been shown to increase cancer risk. And the third thing is people who eat a diet high in sugar and processed carbohydrates or processed foods tend to eat fewer fruits and vegetables, which contain all of those good cancer-fighting nutrients. So they're getting less of the things that actually protect you from cancer. So when patients ask you this question, I think it's really an opportunity to educate them on the benefits of eating less sugar. You don't have to worry that that sugar is going to directly feed your cancer, but there's many reasons to eat less sugar. At the same time, I do find sometimes patients are afraid of eating sugar because of things that they've read typically on the internet about sugar and cancer. Pardon me. So it's also an opportunity to take away some of their fear. You can recommend that they don't avoid fruit because fruit does contain many of those anti-cancer phytonutrients. So they should continue to eat fruit, especially when they're eating whole fruit. They're getting the fiber too that slows the absorption and digestion of the sugar. Keep eating fruit. And the other thing is to not fear sugar. You know, if it's your birthday or there's a holiday and you celebrate with a special kind of cake or with chocolate, continue to do that. What's important is that you don't eat too much sugar at one time. You know, keep it to a moderate portion, maybe have it at the end of a meal, which again helps to slow the digestion and also helps you to feel satisfied with a smaller portion. And then, but so it's important to eat less, but not to fear eating some sugar on occasion. That's my takeaway message. And I've included a link here for a really good resource where you can read more about it or also direct your patients to that page. Okay, as a second question that I have gotten a lot, do people with breast cancer need to avoid soy foods? Sometimes also people with prostate cancer ask this question, and the answer is no. There used to be some concern because the isoflavones, it's one of these phytonutrients found in soybeans. It has a similar chemical structure to estrogen, but there's been a lot of research done on this now, and the research shows that these isoflavones in soybeans function very differently than the estrogen in your body. And they do not increase breast cancer risk. They don't increase the risk of prostate cancer. It's actually been shown that these isoflavones turn on genes that slow cancer cell growth and increase cell apoptosis. So it actually can have some anti-cancer properties. They don't necessarily have to start eating soy foods if they don't like them, but if it's already something they enjoy as part of their regular diet, there's no reason to stop eating them. And that includes processed soy foods like soy milk and also tofu, which is it's kind of a solid plant protein that's made from boiled and cooked up and then solidified soybeans. I'm not sure if you guys have access to that, but if you do, tofu is also safe to eat. And again, here's another resource from a reputable website, the American Institute for Cancer Research, where you can read more about soy and cancer. So another question that's really common is about superfoods. And I think I kind of blame the internet for this. There's so much bad information on the internet about nutrition in general. a lot of talk about superfoods, and it's not that it's not all it's not that it's incorrect necessarily, but when people talk about superfoods, they tend to say that this one food is better than all the other plant foods, and there's just not evidence for that. So what I typically tell people is that all plant foods are superfoods. All plant foods are the fruits, vegetables, but this also includes whole grains, beans, nuts and seeds, herbs and spices, tea, even coffee and chocolate have these phytonutrients, which have health protective properties. They all have different nutrients. Some of these nutrients have anti-cancer properties, they have anti-inflammatory properties, some of them help lower blood pressure, blood sugar. There are so many of these compounds, and there's been a lot of research done on some of them, but there's still a lot of research to go. So there's more that we don't know about these nutrients than what we do know. So to say that blueberries are the most important, or turmeric is the most important, or kale, we just don't have that information. And probably some of these phytonutrients are more important for certain types of cancer, or maybe even for certain individuals based on your genetics. And we don't have enough information yet to be able to tell a person which phytonutrients are most beneficial for them. So, so what's most important, having said all of that, what's most important is that a person eats the widest variety of plant foods, all the different colors, all different flavors of plant foods from all the different categories of plant foods. That's going to give them the biggest variety of phytonutrients. And then that they eat large quantities of plant foods at every meal to get the quantity of phytonutrients. That is going to give them the best health support from their diet, whether it's anti-cancer or just reducing risk of all types of chronic disease. Yeah, so the short answer is there is no one superfood. All the plant foods contain these phytonutrients which have health supportive properties. Eat lots and lots of them. And here's another resource where you can go for more information. Oh, I do want to add here, while there is evidence that some of these phytonutrients may slow cancer growth or even kill cancer cells, it's always an opportunity to let patients know that I don't recommend nutrition instead of medical treatment for cancer. It's something that you do in addition to the medical treatment recommended by your doctor to treat cancer. You want to eat the best you can to support that therapy, but it's not instead of medical care. I always add that. Okay. So lastly, a question that I get often, and really every cancer patient who survives, and fortunately more and more people are surviving their cancer and cancer treatment. They want to know how to reduce their risk of getting cancer again. And this is a summary of those highlights. You want to eat mostly whole foods. Those processed foods have in the processed foods are the foods that come in like a box or a can or a package. And the processing tends to remove a lot of the nutrients from the food, like those phytonutrients, but also vitamins and minerals and fiber. So limiting those foods and eating mostly whole foods, buying them in their unprocessed form, and then processing it yourself, chopping and cooking at home is going to increase or optimize the number of nutrients you get from that food. Filling at least 2/3 of your plate with plants at every meal, eating vegetables and or fruit with every meal. As I already talked about, eating a wide variety of those plant foods to maximize the variety and the quantity of phytonutrients that you get for health. Limiting red meat to a maximum 3 servings per week. And then minimize or avoid processed meats. Those tend to, and I should add here alcohol also, avoiding alcohol. Science is finally telling us that, which we mostly suspected for a long time, that alcohol had no beneficial health effects. So avoiding if possible, or limiting as much as possible. And I'll add here that in my work a few years ago, I created actually it's about a 5-page handout that goes into a lot more detail on all of these points that I would provide to patients who were interested in how to eat for cancer prevention. And that's another handout that I provided to the seminar organizers to share with you. And I welcome you, this is yours to keep, and I encourage you to revise it for your population and for your, so that it reflects the culture of your patients, and whatever their needs are, whatever their questions are. Revise it as appropriate. Also revise it over time as evidence changes. You want to make sure it stays up to date. But that's yours to have and to use as you see fit. And if you have additional questions specific to cancer and nutrition, especially cancer prevention, the World Cancer Research Fund or the American Institute for Cancer Research, they work very closely together. Both of their websites are really strong and have good quality information on those topics. And this is just the first page of that 5-page handout, which I'm sharing with you. Please use it as it's helpful for you. So at the end here, I'm just including some resources. Some of these I shared up above as well. There's the link for the subjective global assessment, which is the screening tool I recommend. It's the most widely used for cancer patients, adult cancer patients. There's the Oncology Nutrition for Clinical Practice and the Pocket Guide for the Nutrition Care Process for Cancer. These are available as online resources, which you could purchase for your hospital, your clinic, for all your practitioners to be able to share and look up information. And here also are the handbooks on nutrition-focused physical exam, and also the physical exam for children and adolescents. And these resources I included on the handout for the nutrition-focused physical exam, which you should also get from the seminar organizers. And some of my references. I really appreciate you all for being here, for hanging in through all of this very detailed information in a short period of time. I hope that you found some useful takeaways, and I'm very happy to answer any questions that you have about this information in any way I can support you. I want to give Mektas a chance to to chime in if she's got something to contribute.
Oh, thank you so much, Stephanie. Like, it was a very interesting webinar. Like, you have presented almost everything, and I know like you have invested a lot of time and effort to prepare this webinar. I want to say thank you, and like if there is any question, like we can answer their question, I think.
Great, thank you so much, Mektas. It was my pleasure. Okay, the first person says, send us the book. I think you're probably referring to, are you talking about the slides? I did provide the slides in a handout form to the seminar organizer, and they will be sharing that with all of you. So you'll have all the notes that I just presented. If there's another book that you're thinking of, could you put it in the chat so I can address that too? Okay, next question. How can we approach a patient who has good appetite but persistent vomiting when they're on chemo despite giving antiemetics? Good question. Yeah, I'm not sure if the person asking is a dietitian or a doctor, but I guess in general, my answer might be similar. That's something to get together and talk about as a team. I would say I never enjoyed working with a medical team as much as I enjoyed working with teams when I was working in cancer care, because I found that the doctors I worked with appreciated nutrition more than other doctors in other services. They were more open to my suggestions, and there was a lot more exchange of information and a lot more sharing, and giving ideas back and forth. It was very collaborative, so I encourage that. So if you're the dietitian, first talk to the doctor, like, how long would you anticipate this is going to continue? And then you want to assess, okay, how much weight have they lost in the first period of time, and how much time is remaining? If they really are not holding anything down, then they're probably not going to tolerate enteral feeds either. And then the practices that I've been in, we would sometimes give parenteral nutrition through the veins, and that can help reduce the risk of malnutrition if that treatment period is going to be going on for an extended period, and you predict that they could potentially lose a significant amount of weight, particularly muscle. Muscle is so important for healing and recovery, and also patients who maintain their muscle through the cancer treatment recover and get back to their quality of life much faster. So there's many reasons to try to protect muscle through cancer treatment. So if you have the opportunity, if you predict that the side effect of vomiting is going to be going on for a long period, and you've tried all the medications, then the parenteral nutrition would be the next step. Okay. Thank you for your thank yous. That's very kind of you. It's really my pleasure to be here and share with you. I really hope it's helpful. Okay, the last question I see here: is there evidence that cancer risk is increased in malnutrition in children? I'm not sure I completely understand. Let's see. Do you mean that they have an increased risk of malnutrition when in children with cancer? Oh yeah. Oh, let's see. Okay, I'm going to jump ahead because this person has given me more information, and I'll come back to that question. So relating to the vomiting with chemo, you say, I'm a doctor and have a patient with gastric cancer taking chemo, but with persistent vomiting despite changing drug regimen. Okay. How can we persuade her personal status? Okay, yeah. Yeah, if you're able to turn on your microphone and talk, it might be easier to converse. Let's see. Yeah. I don't know which antiemetic therapies you have available. I know there's more than one type. So sometimes some patients respond to one type of treatment better than another. So if you have other types of antiemetic medications that you can try, sometimes that will help. I appreciate that gastric cancer is especially difficult because the vomiting may be a result of the chemo, but also the cancer itself. They may be having trouble tolerating anything. If you have the opportunity, sometimes we're able to give enteral feeds directly into the small intestine, and that's a way to get past, if the cancer is in the stomach, it's a way to get past the stomach with the nutrition without having to give parenteral nutrition. That's typically kind of a minor surgery to insert that tube into the small intestine. But it has the added advantage that you're feeding the gut, and that's always a positive. Let's see. Okay, oh, you've tried lots. Oh, it sounds like you tried everything. Oh my goodness. Yeah, that is really tough. That sounds like a tough one. It sounds like you've tried everything you can to manage the nausea and vomiting. So the next best thing is to try to feed them. If you have the opportunity to feed either into the small intestine or feed them parenterally into the veins, that's going to protect their nutrition status until they're able to eat again. It's really the next line of defense against malnutrition in that situation. Your poor patient, that sounds really rough. I hope that's helpful. And I hope you have,
something.
yeah, go ahead.
Oh yeah, okay.
Yeah, you have
I
something
don't
like that,
know.
go for it.
Yeah, sure. I'm not sure if they are available in Ethiopia, but like the neurokinin receptor antagonists, they are really better for chemotherapy-induced nausea and vomiting. So I'm not sure if these drugs are available in Ethiopia, but like they are the most recommended one against like the chemotherapy-induced nausea and vomiting. So drugs which are like the aprepitant, which are like neurokinin receptor antagonists. So if they are available, like it's good to take a chance and to try these drugs as they are very effective. This is my suggestion actually.
Excellent. Thank you so much. We needed the doctor, the doctor insight, so thank you. I hope that's helpful. Okay, I'm going to go back and try to catch the other questions. Okay. Okay, so I think the question that you're asking, does malnutrition increase cancer risk in children? And I don't know that there's any evidence for that. I haven't ever heard that. And if I said something that gave that impression, I apologize because that definitely was not my intention. The concern with malnutrition is not that it increases cancer risk, but that it reduces their risk, it increases their challenge of recovery. It's more difficult to recover from cancer therapy when you're malnourished. I think the other challenge there is sometimes with malnutrition, it's a reason to delay therapy. So sometimes doctors will delay chemotherapy, say they were going to deliver it after 2 weeks, and they have to wait another week or two until the patient is more stable. And that gives cancer a chance to come back potentially. So it reduces the risk of cure. And then in children in particular, the problem with malnutrition is that they're not developing at the same pace they would have been if they were well. And because cancer can be a very long journey, 6 months, a year, a child who doesn't develop normally for a year really falls behind. So again, malnutrition doesn't increase cancer risk, but it reduces the chance of recovery and normal growth and development. I hope that was more clear. Let's see. Okay, the next question, nutrition focused physical exam. Is there a way of grading for that? I'm not sure if I understand the question. Does anybody, Mektis, do you have an idea? Or if the person who asked the question can maybe restate it?
No, I haven't understand the question either. So I think Salamawit, can you like if you can speak, like you can speak out loud and ask your question. Otherwise, like you can elaborate your question in the chat function.
Okay, I'll drop down to the next one. We'll come back to it. How can we calculate calorie intake in cancer patients with other comorbidities? I think you mean like diabetes, hypertension. Let's see. Well, I typically calculate their calorie needs rather than their calorie intake. And the calorie needs don't typically change, or at least there's not a change in the calculation for those particular diagnoses for diabetes or hypertension. The calorie needs are going to be the same, but what type of diet you recommend might be different, like a low carbohydrate diet, a low sugar diet for diabetes to help manage their blood sugars. But the calculation, the process of calculating calorie needs would be the same. Hopefully you were able to attend the first seminar 2 weeks ago when we went through how to calculate calorie needs. And if not, maybe someone else who was there can share the notes with you. And I provided all the information for how to calculate those calorie needs and also protein. Okay.
So we will be sharing the previous handouts as well today.
Oh, thank you. Thank you very much.
I think there is like one question that's saying like, what about feeding jejunostomy if it's unresectable? Yes, like for a gastric cancer patient that was asked before, feeding jejunostomy is also like an option if the tumor is unresectable. But like for some reason, I assume the patient is taking neoadjuvant chemotherapy. I'm not sure, but she wrote that her ECOG is 1. So I assumed like maybe the patient is taking a neoadjuvant chemotherapy. So that's why I suggested like the previous drugs that are the neurokinin receptor antagonists. But if the tumor is not resectable, feeding jejunostomy is also like a good option.
Thank you, Magdis.
Anytime, pleasure.
See, have I missed anything?
Okay. There is another question as well, which says like, do you recommend your patient for dietary change by encourage small frequent meals, avoid spicy, greasy, or strong smelling foods? Yes, like we have discussed this like a couple of weeks ago on the first webinar. We really recommend patients to take small frequent meals, and as you wrote it here, avoiding spicy and greasy meals and foods that have strong smells, and most of the time really hot foods they are not recommended. So you're right, we recommend that as well.
Yeah, excellent. Yeah, we covered all that 2 weeks ago, so you'll find that in the handouts from the first seminar. Okay. I think we covered all the questions.
So I think all questions are addressed, right?
Yeah, it looks like it. Thank you so much.
So yeah, so Stephanie and Dr. Magnus, on behalf of Blue Hills Ethiopia and all our participants, we would love to thank you very much for taking the time to present on our Blue Hills virtual seminar on a two-part series on nutrition and nutritional cancer care, which is a very crucial topic at the moment because it's a topic of question that most patients seek in the case of cancer treatment. Nutrition has been the top tier topic. So thank you very much, and we would love to see you in the future sessions with related topics as well. So if you have any last remarks that you want to add, let me give you back the stage one more time to both of you.
Thank you very much. I'm really grateful for your invitation. It's been a pleasure to share with you all. I hope that everyone's found some information that's helpful. And best wishes. Thank you.
Okay, thank you very much, all of you. The Blue Hills same like webinar organizer, same Stephanie. Like I don't have enough words to thank you. Thank you so much for your time, for your effort. and all the participants and thank everyone. And also like if you want to work for example in revising the handouts in Ethiopian context kind of thing, or like in revising it in Amharic language at any time, like feel free to contact me. I'd love to work with you because like it's really important for our patients to give them, and like they can read it. Like Stephanie has provided us like with the English version, so like translating to Amharic language and um, like to tailor it more or less to Ethiopian context. If you have that kind of like idea or like that kind of plan, feel free to contact me. Thank you so much once again.